going back and touching base on autograft, I know there's different terms, cable, trunk. Can you kind of go through, the nerve autographs, what the kind of terminology is, and then, kind of talk about, I know you just mentioned the sural nerve. Are there any other nerves that you may possibly go to if you're thinking, that you want to use a nerve autograft, and what goes into your head when you try to decide what autograft you want to use? Is it just because it's a motor nerve versus a mixed nerve versus just a purely sensory, all that?
Yeah, I mean, I think it kind of depends on what your deficit is, right? So if you have a digital nerve, for example, or the superficial radial nerve, and you want to repair or reconstruct it with a graft, a single strand graft can be very helpful and useful. And I think that, there's a nice paper out of Baltimore. I think Jim Higgins was the first author in JHS in like the early 2000s, where they looked at the different nerve graft options, and then they looked at the different segments where you would be working on a digital nerve, for example, and looked at where the good size match was. That's a really helpful paper. If you're, a hand fellow or a senior resident, that'll help you figure out what you want to use. But I will say, if it's purely sensory nerve, allograft in my practice has supplanted going and, having that donor site morbidity. If I'm doing if I'm using an autograft, it usually is in a cabled fashion. What you don't want to do is make the nerve graft, for example, like if you had a complete freebie and you could just harvest somebody's ulnar nerve and plop it into somebody's, brachial plexus, you can't just do that without a vascular supply, because what's going to happen is that you have a really thick caliber kind of nerve graft you're putting in. If you don't attach a blood supply, you're going to get central necrosis, because that nerve graft is completely reliant on blood supply coming in from both ends and coming in from the local environment via imbibition. And if you don't provide blood supply, that really thick graft is going to fail. You can probably graft, use a cable graft of like 3 or 4 cables in parallel without attaching a blood supply. And we do that routinely. And I like a sural nerve because usually, like I mentioned, if I'm doing a cabled autograft, it's for a mixed or a motor nerve. And the sural nerve provides the most fascicles. It's a great bang for your buck kind of thing, because when we're doing this, it's a pretty, high stakes kind of thing. And I think most people would agree, if you're doing mixed or motor, use a sural nerve until you run out of sural nerve. The next other nerves you could use are things, for example, if you're operating in upper extremity already, you could use things like lateral interbrachial cutaneous, medial brachial cutaneous, medial interbrachial, PIN, AIN, a lot of options. But they each, that fascicular count and the diameter drops off once you get past sural. LABC is pretty good, but it's not as good as sural. So, in that high stakes kind of thing, until you run out of sural, I would use sural.
Okay. And so just to kind of review, so a cable autograph, that's where you kind of have multiple, small nerve grafts, and you put those in parallel and you try to span a gap. And then the vascularized nerve grafts, that's pretty self-explanatory. It's a nerve grafts where it also has a blood supply to it as well.
Yeah,
And
it's a
then
flap. It's like a free flap. Or if you
right.
rotate it, it's a pedicle flap. But yeah.
Okay. And then the trunk, and that can be kind of mixed motor or sensory nerve grafts. Is that correct?